Hello everyone, today we're going to be talking about substance use disorder. So this video is divided into parts. So in the first one I'll talk about alcohol, in the next one I'll talk about opioids, and in subsequent videos I'll talk about cocaine, heroin, marijuana, amphetamines and so on. So substance use disorder. So what is the diagnosis and DSM-5 criteria? So it's cognitive, behavioral, and physiological symptoms indicating continuous use of a substance despite significant substance-related problems. Substance use disorder is characterized by a problematic pattern of substance use, impairment, or distress manifested by at least two of the following within a 12-month period. Note that these criteria are the same regardless of the substance. So the criteria is the same for alcohol, cocaine, heroin, amphetamines, marijuana, etc. So what is the criteria? What are the criteria? So 1. Using substance more than originally intended. 2. Persistent desire or unsuccessful efforts to cut down on use. 3. Significant time spent in obtaining, using, or recovering from substance. 4. Craving to use substance. 5. Failure to fulfill obligations at work, school, or home. 6. Continued use despite social or interpersonal problems due to the substance use. 7. Reduce social, occupational, or recreational activities because of substance use. 8. Use in dangerous situations such as driving a car. 9. Continued use despite subsequent physical or psychological problems, for example, drinking alcohol despite worsening liver problems. 10. Tolerance, see definition below, and withdrawal, you see the definition below. But if you want to verify their tolerance, basically means that as you keep on drinking, like for example alcohol, as you keep on drinking, the amount that's going to give you the same effect needs to be increased as you keep going on. And withdrawal is basically if you don't get the drug or the alcohol, you're going to experience physical and psychological symptoms. Yeah. So let's talk about the psychiatric symptoms. Most symptoms are common among persons with substance use disorders. Psychotic symptoms may occur with some substances. Personality disorders and psychiatric comorbidities such as major depression, anxiety disorders are common among persons with substance use disorders. It's often challenging to decide whether psychiatric symptoms are primarily or substance induced. Withdrawal. Remember I told you we'll talk about the definition? So withdrawal is basically refers to the development of a substance-specific syndrome due to the cessation or reduction of substance use that has been heavy and prolonged. Tolerance. The need for increased amounts of the substance to achieve the desired effect or diminished effect if using the same amount of substance. So then acute intoxication and withdrawal. Both the intoxicated and withdrawing patient can present difficulties in diagnosis and treatment. Since it's common for persons to abuse several substances at once, the clinical presentation is often confusing and signs and symptoms may be atypical. Always be on the lookout for multiple substance use. So just because of the fact that they presented with alcohol withdrawal or alcohol intoxication, don't just assume that they just take alcohol. There's a high chance they may be taking other drugs as well. So towards the treatment of substance use disorder. Behavioral counseling should be part of every substance use disorder treatment. Psychosocial treatments are effective and include motivational intervention, cognitive behavioral therapy (CBT), contingency management, and individual and group therapy. 12-step groups such as Alcoholics Anonymous, Narcotics Anonymous should also be encouraged as part of the treatment. So basically these 12-step groups they give you 12 steps and then you discuss with the online group and stuff like that. Pharmacotherapy is available for some drugs of abuse and will be discussed later in this chapter as relevant to a particular substance. So now let's begin with alcohol. Alcohol activates gamma-aminobutyric acid, which we commonly call GABA, dopamine and serotonin receptors in the central nervous system, and inhibits glutamate receptors, activity and voltage-gated calcium channels. GABA receptors are inhibitory and glutamate receptors are excitatory. Thus, alcohol is a potent CNS depressant. What do we mean? So, alcohol acts on several receptors such as GABA, dopamine, and serotonin, in the central nervous system. and it inhibits glutamate receptors. So we all know that GABA receptors are generally inhibitory, so alcohol will activate the inhibitory receptors, and glutamate receptors are excitatory, so alcohol is going to inhibit the glutamate receptors, meaning they're going to inhibit the excitatory receptors and they're going to activate the inhibitory receptors, so which leads to the CNS getting depressed. So lifetime prevalence of alcohol use disorder in the US is 5% of women and 12% of men. Alcohol is metabolized in the following manner. Alcohol is converted to acetaldehyde by the enzyme alcohol dehydrogenase and acetaldehyde to acetic acid by the enzyme aldehyde dehydrogenase. There is upregulation of these enzymes in heavy drinkers secondary to a gene variant. Asians often have less aldehyde dehydrogenase, resulting in flushing and nausea, and likely reducing their risk of alcohol use disorder. So, alcohol intoxication. The clinical presentation of alcohol intoxication includes absorption of and elimination rates of alcohol are variable and depend on many factors including age, sex, body weight, chronic nature of use, duration of consumption, food in the stomach, and the state of nutrition and liver health. In addition to the above factors, the effect of ethanol also depends on the blood alcohol level (BAL). Serum ethanol level or an expired air breathalyzer can determine the extent of intoxication. As shown in Table 7.2, the effect of blood alcohol level may be reduced if high tolerance has been developed. What's the treatment? So the first thing is you need to monitor the patient airway, breathing, circulation, glucose, electrolytes, acid-base status. Then you need to administer thiamine to prevent or treat Wernicke's encephalopathy and folate. You have to give naloxone. It may be necessary to reverse effects of co-ingested opioids. A computed tomography scan of the head may be necessary to rule out subdural hematoma or other brain injury. And the liver will eventually metabolize alcohol without any other interventions. Severely intoxicated patients may require mechanical ventilation with attention to acid base, balance, temperature, and electrolytes while he or she is recovering. GI evacuation is not indicated in the treatment of ethanol overdose. However, we are going to talk about gastric or GI evacuation and there are some other drugs. Chronic alcohol use has a depressant effect on the CNS, and cessation of use causes a compensatory hyperactivity. And one thing you need to know is alcohol withdrawal is potentially lethal. Clinical presentation. Signs and symptoms of alcohol withdrawal syndrome include insomnia, anxiety, hand tremor, irritability, anorexia, nausea, vomiting, autonomic hyperactivity such as diaphoresis, tachycardia, hypertension, psychomotor agitation, fever, seizures, hallucinations, and delirium. The earliest symptoms of ethanol withdrawal begin within 6 to 24 hours after the patient's last drink and depend on the duration and quantity of ethanol consumption. Generalized tonic-clonic seizures usually occur between 12 and 48 hours after cessation of drinking, with a peak around 12 to 24 hours. About a third of persons with seizures develop delirium tremens (DT). Hypomagnesemia may predispose to seizures, thus it should be corrected promptly. Seizures are treated with benzodiazepines. Long-term treatment with anticonvulsants is not recommended for alcohol withdrawal seizures. So let's talk about delirium tremens. So this is the most serious form of ethanol withdrawal and it's very high yield. So you need to pay attention to this. The most serious form of ethanol withdrawal usually begins 48 to 96 hours after the last drink but may occur later. While only 5% of patients who experience ethanol withdrawal develop delirium tremens, there is a roughly 5% mortality rate, up to 35% if left untreated. Physical illness predisposes to the condition. Age above 30 and dry delirium tremens may increase the risk. In addition to delirium, symptoms of delirium tremens may include hallucinations, most commonly visual hallucinations, agitation, gross tremor, autonomic instability, and fluctuating levels of psychomotor activity. It's a medical emergency and should be treated with adequate doses of benzodiazepines. Treatment of delirium tremens. So the usual use of benzodiazepines Recommended is chlordiazepoxide, but if there is no availability of chlordiazepoxide, you can give diazepam or lorazepam. Should be given in sufficient doses to keep the patient calm and lightly sedated. Then tapered down slowly. Carbamazepine or valproic acid can be used in mild withdrawal. Then you can administer antipsychotics, but you need to be very careful of lowering seizure threshold and temporary restraints for severe agitation. Then you administer thiamine, folic acid, and multivitamins to treat nutritional deficiency. Electrolyte and fluid abnormalities must be corrected. Monitor withdrawal signs and symptoms with Clinical Institute Withdrawal Assessment CIWA scale. So I have uploaded a video on the CIWA scale. If you're interested, you can have a look at it. Then careful attention must be given to the level of consciousness, and the possibility of trauma should be investigated. Check for signs of hepatic failure such as ascites, jaundice, caput medusa, coagulopathy. So what are the medications for alcohol use disorder? So the first line treatment is naltrexone, which is an opioid receptor blocker. How does it work? What's the mechanism of action? It reduces the desire or craving and the high associated with alcohol. Maybe greater benefit is seen with a family history of alcoholism. In patients with physical opioid dependence, it will precipitate withdrawal. Acamprosate is the next drug. Thought to modulate glutamate transmission, should be started post-detoxification for relapse prevention in patients who have stopped drinking. Major advantage is that it can be used in patients with liver disease. Contraindicated severe renal disease. So first line treatment we talked about what? Naltrexone and acamprosate. So second line treatment includes disulfiram, which blocks the enzyme aldehyde dehydrogenase. I don't know if you remember in the metabolism pathway we talked about aldehyde dehydrogenase. So it blocks the enzyme aldehyde dehydrogenase in the liver and causes aversive reaction to alcohol, such as flushing, headache, nausea, vomiting, palpitations, shortness of breath. However, one thing you need to take note is disulfiram is contraindicated in severe cardiac disease, pregnancy, and psychosis. And liver function needs to be monitored. And it's best used in highly motivated patients as medication adherence is an issue. The next drug is topiramate. It's an anticonvulsant that potentiates GABA and inhibits glutamate receptors. You see action similar to alcohol. It reduces craving for alcohol and decreases alcohol use. So that's all about alcohol and basically the brief introduction on substance use disorders. If you like the video, please like, subscribe, and comment. And then you can move on to watch the next video on opioid dependence. Thank you.